Hello, everyone. Good afternoon. Thank you for joining us for the May QTECH committee meeting. We're going to get started in just a couple minutes. Hello, everyone. Good afternoon. Thank you for joining us for this month's QTECH committee meeting. We're going to get started in just a couple minutes. Hello, everyone. Good afternoon. Thank you for joining us for this month's QTECH committee meeting. We're going to get started in just a couple minutes, but we'd hope that you participate in our word cloud activity. We have a couple different interactive polling opportunities during today's meeting. So in order to participate in that, you can use your smartphone and you would send a text message to the phone number 22333. And then the message to get into the room would be QTECH, so QTECH. Okay, great. We are at exactly 1 minute at the top of the hour, so we're going to go ahead and get started for this month's meeting. Thank you everyone for joining our monthly QTECH committee meeting. We're happy to see you back again to have some further discussions on our topics for today's agenda. But before that, let's go ahead and take a look at the next slide. Just some quick logistics. You have joined the session in a listen-only mode and are muted by default. But if you'd like to participate in any sort of interactive Q&A, you can use that via the telephone audio. You will just need to make sure that you have used the PIN if you are not using computer audio. With that, you can also use the questions panel today during the webinar just to share any questions that you might have. Of course, these sessions are recorded, and so it allows you to revisit it after the fact, and we just want to say thank you again for participating. On the next slide, we just have a screen capture of all the amazing health centers that join us on a monthly basis. Thank you for taking the time out of your busy schedules to join us. So with that, we'll take a look at the agenda today. So we're going to kick off today's session with our welcome and our interactive word cloud activity that you might have seen at the very beginning of the session, which you use your smartphone for that. And just to get your thoughts going, the question is, what are your plans for Memorial Day weekend? So to get that queued up. In addition to that, we welcome back our colleague, Dr. Botts from the High Tech Center and Westat, who's going to continue our electronic patient engagement learning collaborative series with our session number 3 for today. Then we're going to pass it on to have a discussion on social determinants of health. And then in addition to that, we have a colleague with us as well, Fred Ira, who's going to talk about the PCMH education regarding the SDOH requirements. And then we're also going to hear from another colleague of ours, Quasi Willisey, who's going to talk a little bit about National HIV Testing Day, which is coming up in about a month, and provide some key education related to that and our efforts at HCN at ending the HIV epidemic. And then we'll wrap up today's session with some announcements and any other sort of questions that we have for today's session. So I think if we proceed to the next cloud. Okay, so with our interactive, for this to participate, you'll need to use your cell phone. So for this, you would send a text message to the phone number 22333. Then you'd enter the message QTECH. And once you submit that, you'll join the QTECH room for today's session. And then you're able to participate in the live cloud activity as well as the different polling questions that we have queued up. So I think if we look on the next slide, we see the question for today's session, which is, what are your plans for Memorial Day weekend? So if we look on the next slide, I think we can see the responses as they're coming in. Fantastic. So I see some barbecue, a lot of barbecues going on. That's fantastic. It's one of my pastimes. I love to cook as well. Some beach time, a lake vacation. That's fantastic. It's good to get some time away for the long weekend. Someone had mentioned taking a long road trip, pool time, the beach. That's fantastic. It's good to get away for a long weekend or at least get some time to get some sunlight. So that's fantastic. Thank you so much for sharing. So with that, I want to say on the next slide, we're going to pass the floor to our colleague, Dr. Botts from the High Tech and Westat Center, who's going to teach us a little bit more about electronic patient engagement use cases and best practices and findings from that. So Nathan, the floor is yours.
Great. Stephanie, thanks everyone for joining. Great to be back for the 3rd session. And so in this session, what we'll be covering are some best practices and findings in relation to electronic patient engagement. Next slide, please. So hopefully most of you know at this point, but I represent High Tech, the Health Information Technology and Evaluation and Quality Center. We're a HRSA-funded NTAP, and essentially we collaborate with HCCNs, PCAs, and other related NTAPs to hopefully address the needs of health centers out there. And our specific focus is on health IT. And we do so across a number of domains that include, obviously, electronic patient engagement, but we do privacy and security work, general readiness for initiatives such as value-based care, broad health IT adoption, whether it's related to electronic health record systems or remote patient monitoring, and we do quality improvement and workforce development assistance. We do that primarily through our trainings, like the ones that we're doing now, the Health Choice Network, learning collaboratives. We have a website at hightechcenter.org where all these materials are made available, and then do on-demand technical assistance. So if there's anything that we can help you with, by all means, reach out to us, and we'll look forward to connecting with you. All right, next slide, please. So the learning objectives for this session are to examine electronic patient engagement use cases that I'll probably shorten down to EPE. So if you hear me say EPE, I'll be talking about electronic patient engagement. And we'll be looking at some particular efforts related to self-management of diabetes and colorectal cancer screening initiatives. Ultimately, what we're seeking to do is increase awareness of tools and methods that can be deployed. And I'll say that many times I'm focusing on low infrastructure types of initiatives that can be easy to roll out, don't require a lot of infrastructure or investment, or difficult adoption by patients. I think we know there's lots of great apps and resources out there, but sometimes they're not always the best fit. And then really talking through also our patient portal initiatives and how we can best optimize those for use with our patient population. Next slide, please. I hope you all know me by now, but if you're new to the session or missed some of the other ones, my name is Nathan Botts, and I am the electronic patient engagement domain lead. It's an area that I've worked in specifically with FQHCs for many years now, and developed out a personal health record system that we were using with several health centers in California, in the Los Angeles County region, and learned a lot in those efforts, and so continue to learn a lot from all of you as you are working with your patients on electronic patient engagement efforts. So great to be working with you again. Next slide, please. So we've covered some ground previous to getting to session 3, of course, and a lot of what we have been discussing then are really thinking about how we assess the electronic patient engagement needs, how we determine which cohorts we're going to target, and how to best evaluate and determine whether we're getting the return on investment for our efforts. And so let me just touch on those real quick. Next slide, please. So I think, as we had noted before, one of the first things we want to do is actually hone in on our specific problem. Let's say we're talking about wanting to address diabetes complications, or our hypertension goals, or things like that. The first thing we'll want to do, of course, is put it in specific terms as to what we are going after. If we're trying to increase our colorectal cancer screening numbers, then what is our denominator and what is our numerator for determining our target audience? Likewise, if we were looking at trying to reduce A1Cs that are greater than 9%, that we would look at the set of patients who had a measurement during our evaluation period, and then the number of those who are greater than 9, and those would be our target set. And so what we are doing there is saying, okay, we have this issue with this portion of patients who have A1Cs greater than 9%, and within X time period, we're going to be seeking to reduce those numbers. And we think some tools that focus in on particular areas of self-management for patients could be valuable in assisting in our objectives. And so, you're really starting to hone down your specific use case. Next slide, please. And so then we do our math. And so, okay, given that, and so our optimal will be to decrease by how much? And maybe we've been given some very specific guidelines as to how much we want to reduce. Is it simply reducing any percentage to below 9% for A1Cs, or is there a specific number that we're going to try to reach for our numerator? And then given that, what is the current state? And so, okay, that means we would need to have an impact on X number of people. And in order to get to that impact, right, that's identifying our gap there, the difference. And then so we're looking at that specific population and trying to determine what is going to be the best tool or fit for their particular need. And and I make that note there that I know we don't always have a choice. And let's say you were talking about using the patient portal for this objective. Well, it might just be that we have a patient portal that's integrated with our EHR, and that's what we have to use. And so I know you don't always have the complete option, but really what we want to do is based on our unique target population or cohort, determine which tool is best based on their particular needs. And so if that target group is a lot older, and we've done some work in identifying their activation levels, their e-health literacy levels, things like that, well, then using a really fancy tool that may not be as easy for less nimble fingers might not be the best tool for you. Or a majority are second language, English is their second language, and these tools don't have the greatest translation or any translation, and so maybe that's not the best fit, right? And so you really want to make sure that you're picking a tool that fits your audience versus, right, making your audience fit the tool. That's the what we'd like. I know it's not always possible. Next slide, please. And so after we've done our assessments, then we kind of put our patients in different buckets and of how much direct attention, hand-holding will be needed for some versus others. And by better understanding this, you can kind of, when you're doing campaigns of sorts, you can better determine which methods you're really going to focus on based on what you understand of your patients. And so and doing so increases your capacity, makes sure you're getting the right approach. Let's say you're rolling out a remote patient monitoring program and you're going to be measuring blood pressure. Well, some you might be able to hand them a device, give them some instruction, point them to a website or something like that, and away they go, and great, they have the skills and understanding to be able to get it all together themselves. But otherwise, for some, it might take some more direct hand-holding. You might need to go to their home in order to effectively set up such a program. And so understanding those factors is going to obviously increase your success in the particular effort. All right, next slide, please. And so okay, those, we covered that ground a lot in the other sessions and talked about some specific methods. And so that was just kind of getting us back and into the mind space. And so now we're going to look at some different examples of electronic patient engagement, and this set is for diabetes management. So next slide, please. Oh, so first a poll, and I did not confirm with Antoinette or others. Is there a poll available for this?
Yes, we do have a poll.
Oh, fantastic. All right, so the first poll is asking, are you using any particular electronic patient engagement activities for your patients with diabetes? And we'll open it up to both type 1 or type 2. Are you doing anything with your patient portal? Are you utilizing any sort of social networking? There's a Facebook page that you're communicating diabetes information? That counts. Are you using any sort of text messaging or secure messaging strategies, or is there a health app that you're starting to work with your patients on, or any other type of electronic patient engagement tool? Or finally, no, you're not there yet, but maybe you're thinking about it and assessing opportunities. So if you please respond. A, B, C, D, E, F are your responses. All right, so we see, up top, certainly patient portal, and that makes sense, and it'd be great, if anybody wants to, I should have said up front, anybody is welcome to come off mic or chat in if you're doing any, specific activities. In what way might you be leveraging the patient portal? Is it simply making sure they get their, lab results and more quickly and are able to discuss those with the patients? Some of you using some social networking strategies, great. The education piece on diabetes is one of the biggest pieces, and using social networking for communicating diabetes self-management education, whether foot health, eye health type stuff, diet and exercise are all really important. Text messaging, and so we'll take actually a look at a couple of those. No health app strategies just yet. I know there's some pretty cool tools out there. I haven't heard a lot from the field on use of some. So, okay, all right, thank you. Thanks for everyone's response there. So let's say that we're working against the Bureau of Primary Healthcare's diabetes improvement goal. Our performance measure would be our percentage of patients 18 to 75 with diabetes and A1Cs greater than 9% during the measurement period. Our goal is to reduce that, decrease the percent. 1 or 2, we're not giving a specific, but we would like to see our numbers decrease. And so, of course, our numerator are the patients during the measurement period with A1Cs greater than 9. Then our denominator are those with 18 to 75 with a measurement during the time period. And so that numerator is our focus group, and we would want to try to stratify based on that particular number or cohort. Next slide, please. So, with that, so we have our patients in mind, and we know that there's some real barriers to really getting patients engaged in the self-management practices. And so, there's a number of key issues, right? Of course, glucose monitoring, diet and exercise is incredibly important. Certainly medication and appointment adherence are important. And then, patients' just general understanding of their condition. And many different factors can get in the way. This can be, general socioeconomic factors, based on, kind of cultural types of issues, education, economics. There's some just general health belief issues that may come into play, or physical limitations. And so that's what we're trying to do with these electronic patient engagement tools is, hopefully find ways in which those tools can help overcome some of these factors and provide an opportunity to, give the patient a further nudge. And whether that's just, more messaging or, more targeted types of education and things like that, might be our approach. Next slide, please. We have some best practices out there. And so the National Institute of Diabetes and Digestive and Kidney Diseases provide, kind of three key areas that include increasing shared decision-making, really understanding how, what will work best for our patients, motivational interviewing, and so really understanding, their particular perspective and goals in their own health. Maybe it's really not specific to diabetes. Of course, this is something that they have to manage, but maybe they have other comorbidities or aspects to their health that they're more focused on at the moment. And then, setting up some very specific goals on how we can go about creating a care plan that will actually have an improvement on their health outcomes. All right, next slide, please. So I think I've covered this pretty well. Next slide, please. So we looked last time at, in general, when we're talking about behavioral change, there's many behavioral change theorists out there. And, one, B.J. Fogg is fairly well known and identified that really any aspect of behavioral change will require, a motivation, provision of ability, and then a trigger to get them going, right? And so, we'll look at a couple of use cases that try to do that in different ways. Next slide, please. We do have some pretty good evidence to show that these tools can have an impact. And so, it's encouraging, like say in this example, we're talking about patient portals. And we found that, patients provided with portal access show significantly improved diabetes medication adherence and glycemic control. And that not only that, it helps to increase support for patients with diabetes and further reinforce self-management behaviors. And if you'll go to the next slide, most importantly to me is that we see the greatest impact. So we see the greatest impact on people who actually haven't used these technologies before. And we see even greater impact when we roll out tools that include both mobile and more classic or formal computer-based methods. So including both, whether it's the use of particular apps or messaging in relation to the patient portal, we see significant impact on medication adherence with the patient. All right, next slide, please. So one example, this was actually work that we did with the Chicago Health Alliance, and they had a mobile phone diabetes project. And so this was very low infrastructure text messaging program. Essentially, patients enrolled simply received health behavior related text messages related to diabetes. And so didn't require a lot of response on their part. In general, it required enrollment into the program and the ability to receive text messages, but otherwise didn't require a fancy phone or things like that. And importantly, at the end, their assessment, and this was over 6 months, was that including the cost of the mHealth program, the estimated net cost savings per participant of that effort was $437. And our average age was 53 years old, and and average diabetes duration was for 8 years. And so for low cost infrastructure, low touch method, they were still able to derive a big impact and cost avoidance. All right, next slide, please. And then this effort was, essentially extending their reach with their cohort. And so, they identified patients via initial assessment. They enrolled them in a total of 10 hours of diabetes education, and then did follow-ups with them. And then after that was over, and this was pre-pandemic, so those were in-person trainings. After that was over, they extended that period of touch and contact between their peers, to hopefully motivate and continue education by creating a private Facebook support group. And so this is another example where it's utilizing a tool that many patients already access and know how to use, and then simply continuing conversations with their patient population. And so these are just examples of not needing high technology type of projects in order to have a good impact on patients. Next slide, please. Of course, tuning our tools, such as patient portals, will be important in order to have a good impact. And so really making sure that your team understands the tools and know how to configure them in ways. There's some pretty good findings and baselines, discussing the types of things that patients seem to really respond to, and that are informative and help patients be better educated about their health. And so there's a number of findings here. I won't go through each of one of them because of the time, but if you're thinking about these initiatives, and a number of you said that you were working with patient portal issues or initiatives that, finding some of these guidelines can help you roll out those tools even better. Next slide, please. This, again, as always, we want to make sure we're really focusing in on your own population and their specific needs, so that these tools can be more effectively leveraged. And we kind of keep coming back to this because that's where you'll find success. Just simply, just rolling the program out and hoping is not the way to go. So we have to plan and be strategic about how we leverage these tools. Next slide. We find that with health apps as well, and that the more engagement, the more communication opportunities that it provides, and the more opportunities to do self-monitoring with health apps that come with glucometers and things like that are seem to have better results than others. Next slide. All right, so then next is colorectal cancer screening. And so if you're trying to improve your colorectal cancer screening numbers, again, it gets into that motivation, ability, and trigger type factor. Next slide, please. And so we have a poll of what type of electronic patient engagement activities are you using for your colorectal cancer screening patients? Same as before, patient portals, social networking strategies, text messaging strategies, mobile health app strategies, or are you not doing any sort of EPE for colorectal cancer screening? All right. We have a majority not kicking off any initiatives. And this might not be a target for your health center or something that you've taken on yet. It's understood. A number using patient portal again, text messaging strategies. I think we find that it is key for colorectal cancer screening. The whole education and awareness approach is the key. But again, for a target set of our patients, depending upon age and other factors, there's a real drive to increase colorectal cancer screening rates. All right, so a majority haven't kicked off an initiative. All right, next slide, please. Thank you for responding. So the problem here had been, again, that at the state of Illinois, they had found that their national measure was 34% as compared to the national level of 39% in terms of CRC screening rates. And so they wanted to increase that. Key issues were just general avoidance, people not wanting to deal about it, affordability for tests and access, lack of symptoms, right? It's not something that people, really identify or obviously it's not something that they can see, obviously, until it's a real issue. And so, or just a matter of good communication from the provider. The next slide, please. And I'm going to have to move. I see that I'm right up at my time point. So again, we look at the motivation, ability, and trigger factors. Next slide, please. This came out of Monarch Healthcare, and in general, what they did was they leveraged educational and training material that they found on loveyourcolon.org. And so it's great. Loveyourcolon.org provides templates and packets and kind of tools for doing CRC screening rate campaigns. And so again, kind of low tech thing. It's providing extra information on the website, providing cue cards for the doctors, and then you can make this a part of one of your social networking techniques or a secure messaging technique, or something that you highlight in your patient portal. Next slide, please. And so in short, they were using the motivation and ability and trigger piece. And so, motivating, increasing awareness, letting patients know that, this is an important issue and that, screening can reduce complications in the future, and that then it was easy. And so they provided them with the education and the material. The doctors were communicating that information at the encounter. And then the trigger was provision of a testing kit at that time that they could take home and easily use and report back the results. And so this, the best practice was to utilize that MAP type of motivation, ability, trigger type rollout. Next slide, please. There's also some iPad related apps that have been used that can help conduct screening to determine, whether patients should consider taking a test, and then allowing them to easily order one if they decide that this is something that would be good for them. Next slide, please. And so there's, again, some pretty significant results in terms of the impact of the number who got screened utilizing the iPad method. And so they saw, as compared to the control group that did not receive the iPad app, an increase by almost 15% of the number who went ahead and got screened. Next slide, please. All right, so wrapping up, next slide. So, ultimately, one of the most important things, and we've said this a lot in all the sessions, is really it's a matter of having a good understanding of your health center's unique qualities and the patients that they serve. Because if there's just too much going on, or there's a pandemic, or you have lost some staff, or there's just been some general issues in workflow organization, then it might not be the time, or it can make for a difficult time in effective rollout. And so really understanding where you're at and what you can take on at that particular time are going to be critical for success. Your champions really need to understand, both the general patient level needs, but also corporate level needs, and how to what it will take to really sustain one of these efforts and find success, because it's not going to happen all right away. A lot of these things take time. Patient portals that's found can take up to 3 years to really see a big impact on the patient portal registration, use, and then impact on patient outcomes. And in order for us to understand that, we kind of have to go past claims data and really gather more a unique understanding of our patients. I think the discussion that you'll be having on collecting social determinants of health, really ties into these areas of understanding our cohort and then being able to make the biggest impact with them based on that knowledge. Next slide, please. So get your badge. I'll put a link in the chat to this, but just via your participation, if you haven't gone yet, go get your digital badge at the High-Tech Center. So we'll provide some resources related to what I presented here, and then if you fill out the form, you'll get a digital Excellence in Electronic Patient Engagement badge that you can show off to your LinkedIn network and friends, and pat yourself on the back for attending. So thanks so much. Next slide. We have lots of these resources, as I said, at the High-Tech Center site. We have a whole section focused on electronic patient engagement. Next slide. That's it. Any questions, comments? Oh, thanks for pasting that in. Thanks very much. I know we moved, but fast, but of course, if you have any questions, if there's anything we can help out with, of course, reach out to us at either our email address, at our website, or our phone, and we'll get back to you as soon as possible. So thanks so much. I look forward to our next session.
Fantastic. Thank you so much, Dr. Bach. And I'm taking a look at the chat again. Also, feel free if you would like to unmute yourself in order to ask a question as well. That option is also available. I do not see a question at the chat in this time.
Okay. All right.
Perfect.
Thanks,
Thank
everyone.
you so much. Fantastic. So for the remainder of the agenda, we're going to cover a couple different topics. We're going to cover social determinants of health. And then after that, we're going to learn some PCMH education related to social determinant of health data collection. And then we'll pass the floor to our colleague to talk about National HIV Testing Day. So with that, I'd like to start out first on this screen to talk about social determinants of health is one of the Healthy People 2030's 5 overarching goals. So with that, the goal specifically related to social determinants of health is creating a social, physical, and economic environment that promotes attaining the full potential for health and well-being for all. So in line with this goal, they're really focused on highlighting the importance of upstream factors that usually are unrelated to healthcare delivery, but relate to improving health and reducing health disparities. So when we think about social determinants of health, we tie it back to QTECH in terms of our goals. So specifically goal C, using data to enhance value, there's a specific objective related to this, and it's about social risk factor intervention. So the objective in this is increasing the percentage of participating health centers that use both aggregate and patient level data on social risk factors to help support coordinated and effective interventions. So in our annual QTECH program questionnaire, we asked each of you in the last 12 months, did your health center use health IT to collect or share social risk factor data with care teams and use this data to inform care plan development on at least 50% of patients identified as having a risk factor? So when we really think about this question and we break it down a little bit, HRSA is trying to find out if health centers have a routine process for collecting social determinants of health data and determining those patient risk factors. So using not just social determinants of health, but maybe other data points, also known as risk stratification. And then using the data collected to inform at the patient level care plans to address these factors, and then also thinking about the larger approach of supporting any sort of coordinated interventions needed to address some of these risk factors. So with that in mind, we wanted to reset the conversation on this goal and objective by touching on the routine collection of social determinant of health data and share insights provided by a health center during a recent webinar on social determinant of health collection. So to kick off the session, we wanted to start by highlighting a video that speaks to the use case of collecting social determinants of health data called A Tale of Two Zip Codes. So with that, we'll get the video set up for you all. Fantastic. Thank you, Antoinette. So that video really highlights some of the things that, as we all know, were very much exacerbated as well during the pandemic recently. So a lot of these social determinant factors came into play even more so in terms of COVID and the impact to overall health for our patients that we serve. So I think if we go to the next slide, we have a couple poll questions. I want to say we have about 3 different poll questions for you all. And then once we cover those, then we will move to the takeaways. So for this one, we're asking, does your health center have a workflow to routinely collect social determinants of health data? So right now we're split down the middle, 50-50. Oh. Perfect. The majority of folks are saying that yes, they do have a workflow, about 83%. That's fantastic. And of course, some of that data is part of your registration through UDF. Perfect. Okay, that's fantastic. So about 86% of us have a routine process for collecting social determinants of health data today. So I think if we look at the next slide, we have another poll question related to the tool. So here we're asking, which social determinants of health screening tool does your health center use? So there's Prepare, protocol for responding to and assessing patients' assets, risks, and experiences. There's an accountable health community, health-related social needs screening tool. There's also an American Academy of Family Physicians social needs screening tool. D is your health center has not selected a tool yet. And then there's also other. So I see a couple folks are using a different tool. I'd love to see in the chat if you want to add it in the questions, just to share what that other tool might be that your health center is using for this purpose. Okay, fantastic. So it looks like a majority of health centers are using the Prepare tool, which is fantastic. If you're not familiar with that tool, there is a toolkit developed by the National Association of Community Health Centers that's in the handouts for this webinar. So feel free to download that to learn a little bit more about that specific tool. And I'm looking at the chat just to see what folks are asking or putting in reference to the other. So we have a health center that's sharing that they use Prepare, but they're also collecting additional data points on top of that screening tool. That's fantastic. Thank you for sharing. Okay, so then I think if we proceed to the next slide, what we have here is another poll question related to what are barriers that have impacted your health center's ability to either implement or maintain a social determinant of health screening workflow. So it could be a variety of different things. It could be resources, whether in the form of staff or financial or even time. It could be leadership as another one, maybe getting buy-in overall with the organization, time, understood, staffing and time. Great points there. We'll give everyone a couple more minutes to share some of their barriers that might have impacted time it takes to collect. And then I'm going to scroll down to see what it says, but maybe the different types of questionnaires that you're asking during the intake process, that might also be taking up a lot of time as well. Great. Staffing time. Okay, and the number of community health workers to act on the data. That's a great point as well. So it looks like an overarching theme in terms of barriers is staffing and time. So I think if we, well, also people are putting questions in the chat or responding. So this is an interesting point as well. We have a health center that mentioned that willingness for patient participation is a barrier for them. So getting patients to be engaged in the process and want to provide that information and understanding the why are they giving that? So that's a great point as well. Thank you for sharing. And then interest. Very interesting. Okay, so then with that, I'm going to go ahead and transition to the next set of slides that we have here. Thank you for participating in our interactive polling and providing your responses as well within the questions. So for this segment of the meeting, we're going to discuss a webinar that took place recently. So both PTECH and QTECH networks provided a health center spotlight in reference to social determinants of health data collection and referral to community resources. That was actually provided by Siouxland Community Health Center, and their director of quality, which is also a physician assistant, provided some key insight into ways that they were able to implement Prepare as part of their workflow of data collection for this. So on the next slide, we're going to talk a little bit more about those key takeaways in terms of implementation of a Prepare workflow. One of the things that he had mentioned was education of staff and leadership of the value of collecting social determinant of health data. So one of the interesting things he had mentioned was tying it to the mission of how you just care for patients overall and understand and meet them where they are. So this is just a part of that process, right? Getting a holistic view of that patient overall and understanding what the barriers are, because ultimately that could impact their ability to make improvements in their healthcare. Another thing they mentioned was opening up a committee opportunity to the staff who wanted to be involved, also known as asking for volunteers. So if you were going to undertake this process, really making it open to those that are interested or have an interest in promoting this as well as a workflow. Of course, sharing updates on that project during your staff meetings is also important so that they can see the progression over time and the benefit of implementing the workflow. Other things I mentioned were being prepared to address the questions and concerns that come from a variety of different areas, whether it's staff at the health center, administration at the health center, or even the patients, which I think someone mentioned earlier. So what they used were standardized scripts that help open that dialogue with the patients, and it explains a little bit more about the why that data is being collected, why do you want to know that information, and how you plan to help them, knowing what you know about them. The other thing that was very important was he mentioned to stress the point that an answer may not be immediately available, but it's all about starting somewhere to show data collection and see what are the most common barriers that patients are experiencing so that you have an understanding of what partners or partnerships you need to make in the community so that you can create those interventions, those coordinated interventions, and make sure you're kind of trying to close that gap in reference to their social determinant of health risk factor. Another thing they mentioned was considering workflows that don't burden provider, even clinical staff workflows that exist. Other things he mentioned were cataloging the current resources available. So whether it's something you offer in-house or something that you know a community partner is offering for those different social determinant of health data elements, try to catalog those things and find out how you can initiate partnerships if you don't already have one today in reference to that. And then if you don't have them, or you do, you have those resources, try to find a way to see from the patient's perspective, what was the benefit? How was their experience using that resource, which Fred will talk about with us in a little bit today. And the last piece actually starts on the next slide, which is looking at the 5 rights framework and a PDSA cycle to help develop that workflow. So on the next slide here, we're looking at the 5 rights here. So these are the 5 different things or questions or areas to ask as you're going about implementing or even trying to improve the process for collecting this data at the health center. So it starts out first with the what, so the right information. So how is the tool going to be administered to the patient? You want to make sure you're accurately identifying what their experience is with social determinants of health. You also want to know the how, so in the right format. So how will this information be collected? Will it be in a paper form and then printed out and then transcribed at a later time? Is it something done in the encounter note? And also in addition to that, where is that information organized? Is it readily available to all the staff that need it, that will be conducting this with the patient? Other things are the who, so with the right people. So who's going to address the social determinants of health that are identified? Is there an easy way to have a resource for the folks that are doing that at the health center so that they can get the information they need to the patient as quickly as they need to? Other things are the where, so via the right channels. So is there an appropriate care team member that's identified to help with this? Is it a medical assistant? Is it a triage nurse? Is it maybe one of the staff in your enabling services area of your health center? And then of course, when at the right times. So when does it make sense during the visit process to administer the tool? And I believe on the next slide, we have a couple different breakdowns of the workflows that were shared. But before that, we're going to talk about different categories here. So one of the things that they mentioned, and I think Dr. Botts also mentioned earlier, was deciding on what populations or groups to screen. Maybe you want to take an approach where you try to do a PDSA on a smaller group of patients, whether it's in the case mentioned earlier, diabetes, focusing on those patients that are diabetes with different risk factors and figuring out, let's try to roll out the SDOH process or workflow with these patients, see how that goes, make improvements to then consider opening it up to other diseases or medical conditions and populations. And then overall, what they ended up doing was making it part of their standard process. So annually for their entire population, if that patient was a patient of the health center, they were impaneled or assigned to a health center PCP, then they would do this on an annual basis to prepare a screening tool. So that's something to think about overall for long-term goals. I believe on the next slide, we have the different workflows here. So there were two options that were provided. One of which is that the health center has the charge nurse or medical assistant provide that prepare printout to the patient and either can review it verbally with the patient in the exam room or may give them the printout and then walk away to give them some privacy and allow some time for the patient to complete. Once it's completed, then the charge nurse or medical assistant comes in to review and asks the patient to clarify. And then if it's a case where it's a positive response to one of those factors, then it's something potentially quick to resolve, that nurse or MA will then provide the resource to the patient via a CHC intranet site. So they have within their intranet site, there was a website link that led them to an Excel document that we'll see in another slide that breaks down the different questions or elements of the prepare screening tool and ties exactly links of printouts that they can have right then and there to give to the patient. Now, if it's a positive response and they identified a more complex issue, then what was the next step on this is a charge nurse or MA is then referring that patient to either the behavioral health team and or a case manager, a nurse case manager to resolve some of those in further detail. At the end, they have a provider review and sign off on that paper form so that they're aware, and then that then becomes entered into the EMR. That was the first workflow. The second workflow just is a little bit different in where they're actually engaging the front desk to determine if a patient's due for the prepare. As I mentioned, they have an alert built in so that they're doing this on an annual basis. So if the front desk identified that, then they actually would provide a printout to the patient and allow them to complete that with other sort of registration documentation or needs. And then once that information is collected, it's then handed to the charge nurse or medical assistant to do that in-depth review and figure out next steps if there is a positive response. On the next slide, this is just a screenshot of what that Excel document looks like from their intranet site. So the way they have it built, as you can see, it's a little bit blurry, but this is the money and resources column. So that was a set of questions asked in the prepare tool. And here you're actually seeing two different versions of handouts that are beneficial in those cases, one in English and one in Spanish as well. So those are the resources that we mentioned that are being printed out for the patient if it's something quick to resolve in that sense or provide an intervention in that manner. On the next page, I want to say that we have, here's an example of one of those screenshots. Again, just one of the food pantry options for the patient that they're easily able to print out from that Excel document and provide to the patient. On the next slide, here's just a case study they did. So again, thinking about the collection of the data overall and having that be that starting point, they actually had a case study specific to their diabetes population, where they were able to do a comparison of those controlled diabetes versus uncontrolled diabetes, and looking at those different social determinants of health factors, and trying to pinpoint one in a way that they knew they could make a difference immediately. So in terms of food insecurity, something interesting they did with this data is figure out that they were able to do partnerships in the community with farmers, that they actually had refrigerated units available to their patients in the waiting area so that they could grab produce as needed. So that was out there in the waiting room for them to grab food as needed. And then the farmers just came by and dropped off any sort of fresh produce. So that was accessible to them during their time at the health center. So that was an interesting case study that they had presented. Fantastic. So I think if we proceed to the next slide, we will hear from Fred Ira, who's going to talk about PCMH specific education related to social determinants of health and how that's important process to have in place. So Fred, the floor is yours.
Thank you, Stephanie. Good afternoon, everyone. My name is Fred Ira, and I'm part of the clinical quality team. I serve as the practice transformation coach and as one of the PCMH clinical content experts at Health Choice Network. I was asked to speak to the group on PCMH and social determinants of health today. I'm going to share with you some tips and tricks on how social determinants of health incorporates with your PCMH transformation application. Now, I'll preface this by saying that I will be referring to NCQA PCMH standards and criteria, but it's generally the same for AAAHC and with the Joint Commission. Next slide, please. Social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health can be grouped into 5 domains. The first being economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Social determinants of health also contribute to wide health disparities and inequities. For example, people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. That raises the risk of health conditions like heart disease, diabetes, and obesity, and even lowers their life expectancy relative to people who do have access to healthy foods, like in that wonderful video that we saw. Just promoting healthy choices won't eliminate these and other health disparities. Instead, public health organizations and their partners in sectors like education, transportation, and housing need to take action to improve the conditions in people's environments. Next slide, please. So I've put together a PCMH and social determinants of health plan that will help your health center succeed in using social determinants of health in order to better health outcomes. As you can see, this is a 4-step action plan for success. Next slide, please. The first step is to collect the data. Whatever tool that your health center is using, it is important. This is an important step in the process. I know that much of this data is gathered upon registration, but I would strongly recommend that we use some sort of tool regularly to collect this social determinants of health data. As you can see, collection of the data is a core criteria in the patient-centered medical home process. The core criteria are the building blocks of PCMH. Gathering of social determinants of health is one of the things that NCQA requires as part of the comprehensive health assessment, on top of all the other things that you see here. Next slide, please. NCQA uses examples like availability of resources to meet daily needs, access to educational, economic, and job opportunities, public safety, food and housing insecurities, socioeconomic conditions, and others. Next slide. Step 2 is to build that resource list. The expectation is that you look at your population served and you prioritize based on the needs of that population. You should use predominant health conditions, EDUs, and other health concerns in order to prioritize the community resources. As you can see, that building that resource list is also a core PCMH criteria. Next slide. The second part of step 2 is to have that list available to your patient population. Whether it is a physical list or access to such resources online, the resources should be made available to your patient population. Next slide. Step 3, which I feel is the most important step in the process, is to take action with the data that you have collected. What good is data if we don't have any, if we don't do anything with that data? What good is having resources available if we don't tie them to our patient population that could benefit from these resources? I think this is where some of our health centers struggle in tying our patient population to the resources available to help with social determinants of health. Next slide. The last step in the process is to periodically assess the usefulness of those resources. They recommend getting feedback from patients who have used or have been referred to the resources, and as an organization, decide on whether you will keep referring patients to that resource. An updated and relevant list is an important tool to have. If your health centers follow these steps, you will find that you'll be better able to connect your patient population to available resources in the community and to better their social determinants of health and improve health outcomes. As a bonus, if you follow these steps for success, you will have collected 2 core criteria credits and 4 elective criteria credits towards your NCQA PCMH transformation application. Next slide. Lastly, HCN is here to help you with all of your PCMH needs. If you have any questions on this topic or any other PCMH topic, please feel free to reach out to me, or you can send an email to askyourcce@hcnetwork.org, and any one of the 4 CCEs here at HCN can assist and answer your questions. Thank you.
Thank you so much, Fred. Fantastic presentation. And we are here to support you throughout the process. So with the folks who might have mentioned earlier that you do not have a workflow yet for collecting this, we'd be more than happy to assist you with that process. So I think on the next slide, we're going to turn the floor to our colleague, Quacey Willisey, who's going to talk to us a little bit about National HIV Testing Day. Quacey, the floor is yours.
There we go. Hi. Good afternoon, everyone. Thank you very much for this opportunity to highlight National HIV Testing Day and also just to discuss what we're doing here in HCN regarding HIV in general. So can we please move to the next slide? Next slide, please. Okay, well, National HIV Testing Day began in 1995. I'm sorry, well, can we go back just one? National Testing Day began in 1995 to pretty much encourage as many people as possible to get tested for HIV. It's integral that we actually speak about testing because it's a big part of HCN's journey to ending the HIV epidemic, which I'll be explaining in a little bit. But again, at the height of the epidemic, where it was no one cause of death for young people in the United States, there was outcry because not enough people were getting tested. And from what we found out, 26 years later, next slide, please. 26 years later, we're still in the same predicament because not enough people are getting tested for HIV still. So how we know this? Well, from data in 2018, only 39% of the United States population who were eligible for getting tested for HIV or recommended to get HIV tests had ever been tested for HIV. So that means that 61% of those individuals who should get tested had no idea whether or not what their HIV status would be. In addition to that, in 2016, CDC analysis shows that a vast majority of about 80% of the new HIV infections in the United States were transmitted from nearly 40% of the people who were HIV positive. And these were the individuals who did not know that they had HIV in the first place, or they knew that they had HIV, but they were not engaged in proper medical care to reduce their viral loads. On the flip side, 51% that were HIV positive and taking their medication were virally suppressed. So the takeaway message from that is that people who know their status and people who engage in the care continuum and continue to take their medication are the individuals that are helping us in regards to preventing new transmissions of HIV in the United States. So we all know that testing is a good thing, or the general population might know that testing is a good thing. However, next slide. However, what we found is people still don't want to be tested, and that is for a variety of reasons. So why would someone refuse to be tested? Well, the key reason is because of stigma. And I'm sure that a lot of people are probably aware of this, but the stigma of HIV is one that has existed from the beginning, and it still persists today, especially in some population more than others. And it's really the biggest barrier regarding changing attitudes to the test is concerned. So the stigma is associated with a history of homophobia from the beginning, where HIV and AIDS was referred to as GRID, gay-related immunodeficiency disease, and also the gay plague. In addition to that, just how the administration at the time, the Reagan administration, was very slow in moving towards controlling HIV and sending a message where it would have probably helped a lot for individuals that were especially at high risk of contracting HIV. But that history of homophobia tied in with the fear of moral and religious judgment, for individuals that think that, well, if I go get tested for HIV, that would give the impression that they are either morally corrupt or morally bankrupt, along with the fear of testing positive because of the lifestyle changes and societal attitudes towards it to HIV positive people, fear of social isolation, and fear of medical institutions, which goes way beyond the Tuskegee experiments. For those who have no idea what I'm talking about, please take a moment and investigate the history of that, along with the history of gynecological experiments in the United States from the days of slavery all the way up to today, and criminalization of HIV due to outdated laws, which were written in the early 80s that was done at a time when both the science and data around HIV was limited. So all of these are huge deterrents for individuals to actually go and get HIV tests. So in order to address this, next slide. In order to address this, the new National HIV Strategic Plan, which was released in January of this year, had a bold vision in which the United States will be a place where new HIV infections are prevented. Every person knows their status, and every person with HIV has high quality care and treatment and lives free from stigma and discrimination. This vision includes all people regardless of age, sex, gender identity, sexual orientation, race, ethnicity, religion, disability, geographic location, or socioeconomic circumstances. So pretty much everyone. Next slide, please. Right. So the goals of the new strategic plan is firstly to prevent new HIV infections, which is what we're going to be focusing on today, and improve HIV-related outcomes for people who are HIV positive, of course, reduce HIV-related disparities and health inequities, and also achieve integrated coordinated efforts that address the HIV pandemic among all partners and stakeholders. Next slide. Next slide, please. So what HCN has done is we've approached this, well, we focus firstly on the first goal, which is to stop HIV transmission. And the second objective of that goal, which is to increase the knowledge of HIV status of the general population. We decided to hone in on that and make that a part of our mission and our mode of operation for our HIV program. So the first thing we did is coordination. We coordinated multiple organizations to share best practices and work towards quality improvement projects in HIV testing and care. Secondly, policy updates. We standardized opt-out testing as the HIV screening policy for community health centers in hopes to remove stigma and increase testing increased testing census. So there are many, this is a best practice, and it showed evidence that it really works once there's a blanket policy that says everyone is going to be tested, and HIV testing is a routine part of the care provided by the community health center, that individuals are more likely to get tested and less likely to opt out of getting a test. So that, along with electronic medical records enhancements, where we leverage our electronic medical record to be a driving force in order to identify clients in need of HIV tests, identify clients that will benefit from PrEP and other HIV prevention services, and link all HIV positive clients to care, and also to correctly collect reliable testing data as well. We're hoping that we'll be able to establish a status neutral approach to prevention. And what a status neutral approach is exactly. Can you move to the next slide, please? It's basically an opportunity where anyone that's tested will be either provided treatment and engaged into the care continuum if they're HIV positive, and retain them in treatment until the person reaches a level of undetectable. So if the person is undetectable, we are aware of undetectable equal untransmittable. If the person is undetectable, meaning that they have a very low viral load coupled with the use of condoms, the probability of transmitting HIV to someone else is vastly removed. In addition to that, in addition to that, for high-risk individuals that get tested, they're identified at high risk, they're educated about PrEP or pre-exposure prophylaxis, and adhere to PrEP medication along with using condoms, the chances of contracting HIV is also reduced. So by combining both of these efforts, hopefully we'll be able to really end the HIV epidemic by 2025, which is what the new strategic plan is pushing towards. And again, it all begins with making sure that we have testing policies that will cast a wide net and also have the supporting electronic medical record and also workflows that will help to make this transition to zero transmission, as efficient as possible. Can we see the next slide, please? So here, I would like to present to you a small roadmap of what we are doing in regards to our electronic medical record enhancements. Right now, everything is done through Greenway and Intergy. However, the goal is to be EMR agnostic. So far, we've released HIV reminders to help identify individuals that may need to be screened for HIV, and the frequency of these tests will be determined by the provider based on the person's risk factors. Pre-exposure prophylaxis package, which includes a PrEP reminder that also helps to identify a person that may be at high risk of contracting HIV that may benefit from using PrEP, along with PrEP forms, lab orders, sets, and workflows and checklists, which is in the works currently. We are in the process of releasing our HIV linkage to care form and workflow, along with patient education as well. This should be released this week. We're working on HIV care forms, checklists, and lab orders to help reduce burden on the provider and also help to make the experience for the client a lot more palatable. And also in the future, we'll be working on telehealth, because there's a lot of work right now that's showing the benefit of using telehealth in PrEP services and also HIV care follow-up. At the bottom of our priority list is post-exposure prophylaxis, but that's also included too. So the take-home message that I'd like everyone to hold on to is, yes, there's still a need for increasing HIV tests. There are many ways in which we can do that, not only on National HIV Testing Day, but also just through making HIV tests a routine part of medical care through a solid policy that removes stigma, and also by engaging our clients into biomedical interventions, be it PrEP or through antiretroviral therapy. So I'm hoping I'm doing good on time, but I really want to thank everyone for your attention to this serious matter. And you can move to the next slide, Anthony. Thank you. And thank you very much. If you have any questions or are interested in learning more about what we're doing, or you would like to include this into your plans for your community health center, please feel to reach out to me through Stephanie Smith. So Stephanie, I'll pass on to you.
Fantastic presentation, Kwesi, and thank you for sharing that knowledge with all of our QTECH committee members today.
Pleasure is mine.
Fantastic. So I think if we go to the next slide, we will be closing out today's session. So thank you for attending. Of course, we look forward to having you join next month's meeting as well, where we're going to end actually the Electronic Patient Engagement Learning Collaborative series with HITECH. So be prepared for that. Also, we have an upcoming webinar on June 4th in reference to achieving wellness and resiliency through mind-body medicine webinar, which we'll have on the next slide. And then, of course, another last item here is let us know if your health center is interested in presenting a spotlight. We do have one currently in queue for next month's meeting in reference to social determinants of health. So we're looking forward to hosting them and having that opportunity for them to share from their perspective. But we welcome all of you to come and join as well and share some of those best practices or things that workflows you have in place to help support quality throughout the network. We really appreciate that. So then with that, here's the QR code if you're interested in attending this webinar, Achieving Wellness and Resiliency Through Mind-Body Medicine. We're going to have a health center provider from one of the Alliance Chicago health centers who's actually going to talk to us about some different techniques, some mindfulness techniques to help alleviate day-to-day stress, as well as different ways to help with that process. So we look forward to hosting you for that opportunity. And I think with that, that leads us to our last slide. We look forward to seeing you all next month, June 24th. Have a fantastic rest of your day, and we look forward to seeing you then. Reach out if you have any other questions in reference to the items discussed today, or if you have any reference items that you want to touch base with us in reference to clinical quality. We're here to support you all in those endeavors. So thank you for your time. Have a fantastic rest of your day.